Okay, let's get into hypothermia. What? I may just give it away. All right, it's cold, but. So this one is a case study, essentially. So let's dive right into this one. All right, you're dispatched to a man down, not acting right. Okay, happens all the time. You arrive on the scene. It's a cold day in the upper 20s, mid-February. The scene is safe. Caller meets you in the driveway, explains that he can see his neighbor through the window on the floor. You make entry into the house, and once inside, the home itself feels cold. So, what do you find? Your scene. We already said it was safe. You have a patient lying on the floor inside his home. Her home, his home, whatever. Patient is unconscious. What other additional resources would you need? Perhaps we could have asked that question a moment ago when we actually were trying to gain entry into the home. You make contact with the patient and you are having a hard time finding a radial pulse. You do find a carotid pulse, but it is weak and irregular. So our findings, physical findings of the patient, is airway. With assistance, patient is rolled onto his back. The jaw thrust maneuver is used, and the airway is open. Snoring goes away. Respirations are shallow. Lung sounds are diminished. You have a pulse oximeter that is not working right or is unable to find a pulse in the fingers. Remember, we had a very weak or absent radial pulse. And the respirations are only about 10 per minute. You check pulse under C for circulation and consider attaching a monitor, but your electrodes will not stick. The skin is very waxy and cold with even some peripheral cyanosis. You're unable to get a blood pressure. You have a carotid heart rate of nearly 40, and now respirations are about 6. You pull out your handy-dandy trusty thermometer every EMS unit has, and you scan, and your thermometer says 87.2. Clearly something everyone kind of scratches their head over. Should I trust that thermometer? Let's just say in this scenario, yes. I already told you it was a cold day. It's February. It's in the 20s. With what we know so far, yes. Let's assume that that is accurate. An accurate 87.2 core temperature. And a glucose of 92. Everyone does a sample survey, right? A sample history. Signs and symptoms. We already know these mostly. Unresponsive to pain. Unresponsive does respond to some painful stimuli, purposeful movement. They are cold to the touch. They have bradycardia, bradypnea, some peripheral cyanosis, and they've been incontinent of bowel and bladder. Cannot find any medical alert bracelets. You find a shoebox on the table with a variety of medications, including insulin and furosemide. Past medical history. On the basis of the meds you find, you can figure type 2 diabetes, CHF, AFib, and hypertension. Don't know for sure when they last ate, but you see a meal that was delivered about 2 days ago, which appears to be about half eaten on the table. So I know a lot of you are thinking diabetes, but remember we had a blood sugar of 92. Patient was last seen awake and ambulatory 2 days ago. No evidence of trauma. Okay. Let's get into some reversible causes, H's. Hypovolemia. What do you think about that? Let's discuss those for just a moment, each at a time. Patient's arms are stiff and cold. No signs of fluid loss or other than the urine and bowel. Turgor is poor, and the skin was cold and waxy. You can get an IV established, and you have some fluids going. Would you prefer regular out-of-the-bag fluids, or would you go with, that sounded kind of funny, but would you go with regular fluids out of your jump bag, is what I meant to say, or would you go with some warm fluids out of an IV warmer? And would you consider boluses at this time? We cannot get a blood pressure. And boluses, what and how much would you consider? Right, hypoxia. You notice that there's peripheral cyanosis. Slow and shallow respirations, so hypoxia is probably going on. Hydrogen ion, in her current state, is it likely she has some sort of metabolic acidosis. Hypothermia. I skipped one, pardon me. Hyper or hypokalemia. There are, of course, not normally seen in the EMS world, but there are handheld blood analyzers that can tell you that, which is something you may see in the future. So at the moment, we're going to consider, yes, possibly one or both. We don't know. And hypothermia. And I think everyone's on the same page now that hypothermia is probably the situation here. So if we're calling this hypothermia, what degree? Mild hypothermia is considered anything less than 34 degrees Celsius or 93.2 Fahrenheit. Moderate is anything, let's just stick with the Fahrenheit. How about that? Anything less than 93 to down to 86 degrees Fahrenheit. And severe is less than 86 degrees Fahrenheit. And then a profound hypothermia is even colder than that. So the definitions of severe and profound are actually the same. Does this patient warrant gentle handling? We normally hear that we should not jostle and move these patients around quickly, but this is a load and go situation or a stay and play. Hypothermic patients are often volume depleted from cold diuresis. Remember, she's been incontinent. She has a dysfunctional cardiovascular system and mechanisms. So we should avoid excessive movement with her. We don't know what medications she actually has in her system. They just haven't metabolized yet. We do not need to delay an urgent transport, though, so do this with consideration. So we can intubate her. We can have her IVs, which we already have. If intubation is necessary, that's okay. And chest compressions. There's plenty of conversation about because of the exposure and her current condition that until she warms up a little bit, we should not be pushing a lot of medications. The reason for that is the reduced metabolic rate. And we don't know what drugs she already has on board. We have a shoebox full of medicines. We don't know what she has taken and when. But the drugs that you might be considering, your epinephrine, your lidocaine, your amiodarone, whatever, any of your ACLS meds, any of your other drugs that you can consider right now, probably should be held until we have a warmer body temperature because of the reduced drug metabolism. Drugs like epinephrine and lidocaine may accumulate to toxic levels if used repeatedly in this severe hypothermic patient. So we don't want to cause a rapid bolus of those drugs when she does get rewarmed. All right, moving on to the T's. No reason to suspect a tension pneumothorax? No. Lungs are clear with little air movement on both sides. No narrowing of pulse pressures or JVD, so no reason to consider tamponade. Pupils are equal and slow to respond to light because of all the medicines that she has, and they call that polypharmacy. Could be considered the toxins. So thrombosis, pulmonary PE might be a possibility with her stasis and clear lungs. You actually can't tell. We can't measure pulse oximetry, so we don't know how well she's oxygenating. And a coronary thrombosis. We're working on 12 lead here in a moment. Well, let's consider other medical problems in her list of drugs that we had in that shoebox, and we can also compare that to our list of likely medical history or medical diagnoses. We can also consider things like Well, we considered diabetes. She had hypertension, poor nutrition perhaps is part of an issue here. She lives in a nice home, but maybe she lives alone. We had a half-eaten meal that was delivered a couple days ago. And she's septic. What's the temperature in the house? Is there a socio-economic reason that she cannot afford to have her thermostat, set at a reasonable temperature for this time of year? So we already mentioned earlier in the lead into this that the house felt cool. It's cold outside, so it should be cold, I guess, would be expected, or cool to be expected. And we do see a little bit of a problem with tracing clarity here with the 12 lead, but we see a fairly ordinary looking 12 lead. We have some T waves. No, pardon me, those are not T waves. Note in here the J or Osborne waves, and I'll show you a better screen here in a moment. No evidence of STEMI. We'll get into that J and Osborne wave here in just a moment. So let's just go ahead and move to that now. So this is her actual 12 lead. Note those J and Osborne waves. So what you see there is on the downslope of the R wave is a little notch there known as a J wave. The other picture here is the Osborne wave, or there are positive deflections occurring at the junction between the QRS complex and the ST segment, where the S point is usually found, or the also known as the J point, that has MI-like elevation, but that's not indicative of an MI in this case. So J wave right there, and the Osborne wave a little more obvious to see. All right. Hypothermia. Possibly impaired thermoregulatory function occurs in most or in several age groups, like the elderly, homeless. She is not homeless. She lives in a very nice house, actually. She's not disabled, but she is chronically ill. Others at risk would be the insulin-dependent diabetics, and we had a type 2 diabetic with no insulin. She's not likely intoxicated. She does, like I said, have a nice residence, but we don't know her economic situation and her finances, so we don't know, but we can tell by the heat in the home. So we should be able to get an idea how well she's able to heat her residence. All right, should we consider rewarming her now? First off, we're going to prevent any additional heat loss. She doesn't have any wet garments, but she did have I guess she does actually. If she was incontinent, we probably need to remove those, cover everything up, try and keep everything warm. We already have the warm fluids going, so some passive rewarming is moving. Passive rewarming, alone will be inadequate for her, but we have some rather active rewarming going with the IV fluids. So there's our question about rewarming in the field, and we are adjunctively, you are providing some rewarming in the field with your warm IV fluids. So that is underway. So now we can discuss whether or not let's work from the bottom up here. We talked a little bit about potassium. We don't know for sure what it is. We don't see any marked evidence of that on her 12 lead. We already discussed our medications that we might be giving. She is not in a cardiac arrest state right now, but if she were to arrest, we would have to start CPR and defibrillate rhythms as necessary. And we might probably should consider holding our medicines until we get some a repeat of a thermometer or a temperature and see where her temperature is. They're just not going to be that effective until she begins to warm into the 90s at least. Right? What if assuming that this patient went into arrest, And if the patient regains ROSC, thanks to your wonderful compressions and high quality CPR, we were rewarming this patient for quite a while there with all that, so she's getting warm fluid and beginning to rewarm now. Might be significant hyperkalemia from that, so we could consider some sodium bicarbonate for her at that point. Because of severe hypothermia, it's frequently preceded by problems such as drug overdose, alcohol intoxication, or trauma. We don't really have reasons to suspect that with her. We should look for, though, and address those underlying conditions while treating her hypothermia. No reason to suspect chronic alcoholism or malnourishment with her, but we should consider that idea at least and take an extra moment to look around the home for evidence of that. And a lot of us aren't carrying thiamine anymore, but it's certainly a potential consideration if you do. All right. Continue rewarming to the target post-resuscitation ROSC temperature. Monitor all her hemodynamics and volume administration. And address underlying conditions. So basically with this case we have a elderly woman who lives alone. It's cold. Maybe she doesn't have the finances to have her heat turned up. She just has, with her medical problems and everything, she has had or suffered an accidental hypothermic condition. So in summary, this particular one has a severe accidental hypothermia that we can correct. It's still reversible. She'll potentially have some cardiac irritability. And if she does go into VF, routine ACLS should be followed and begin to treat hypothermia as soon as possible, which we did with the warm fluids like thrombocytopenia, metabolic acidosis, poor glycemic control, and even the risk for infection in these patients. Potential problems down the road for this person. And it'd be good to continue getting a repeat or a secondary hypoglycemic or a blood glucose level on this person. All right, that's the end. Thank you.